that Vincent pulled up. So it's a long time. It's nothing that you should be afraid about because it's nothing special. It's a magnifying technique. If you use loops, that's a magnifier. If you use a microscope, it's a magnifier, and endoscopy is a magnifier. The only difference is with the microscope you're here, and with endoscopy you're here. So it's good if the patient is very big, because you don't care, but you can get lost very easily. So what you saw today, what Vincent showed you, we've come a long way until we were here. So I would say 10 years ago, 15 years ago, half of these techniques didn't exist. One of the techniques I'm going to talk about is like the newest development that we've had in endoscopic surgery for the last 10 years. So I'm going to show you a little bit. This is my disclosure, so don't believe a word I say. And this is the clinic I work in Barcelona. So my whole point of view is I start with pain. You know that pain is an issue during surgery, after surgery. This is something that you want to control. And you know there's been an opioid pandemic in the US. It's been a big thing. And despite all the problems with the opioids they have in the US, the median prescription duration of opioids is the longest for spine surgery. We spine surgeons give the longest duration of opioids for median of 13 days, which is quite a lot postoperatively, all right? So I have two pain control strategies in my center, which is first the surgery and then the analgesia. And I'll talk about both things today. So what I try to do with the surgery, you all know what MIS is, what the idea behind is, less pain, less blood loss, and especially you get early mobilization. There are tons of studies showing that if you put a patient on their feet, the sooner, then the less complications you get. And this is my main target when I do a surgery, of course, and getting the pain away. So the last 10 years, we've been developing endoscopic or percutaneous fusion. And the whole idea is that we use Cambian's triangle, which is this triangle that you can see here between the exiting nerve root, the SAP, and the platform of the lower vertebra. And if you stick into this triangle, then you can bypass the nerve root safely. Okay, this is the basis of the transforaminal endoscopic approach. You will see later in the workshop, but it's the same idea. So usually, if we go through that, you don't have to do a big facetectomy, all right? You don't have to take the whole facet out. You can go in through the foramen, place a cage. In endoscopy, we usually use expandable cages because then you have a larger footprint. And this is how it looks like. So it's a similar approach like the endoscope, and then you can slide a cage in, all right? And of course, this allows for early hospital discharge, and you can do it awake. So you can do it with sedation. So we've been doing this for a long time. So my father described his first case in 2010. And then we've been experimenting with different kind of expandable devices. This one is back from 2011. And this is how a usual case looks like. You can see here the expandable cage. You can see here the incision for the placement of the cage. Very small incisions for the percutaneous screws. And you can see the expanded cage. And the whole idea of indirect decompression, you can see it clearly here with the expandable cage. I think this is a nice depiction of what you get. So you can also, when you have foraminal stenosis, you don't only do a direct decompression of the foramen with the endoscope, you can also do it with indirect decompression using the cage. More ideas. So I'm not saying this is better or worse, I'm just saying it gives you another tool set that you can do. So if you have revision surgery, and usually you will have the scar tissue in the back, you can go through another way, the posterolateral way, and avoid the scar tissue. So if you avoid the scar tissue, like in this male that came to us, he had been operated in elsewhere, and you can see that he had a TLIF only with a cage on one side. He had the foraminal stenosis on the other side. We did a CAT scan. The instrumentation was fine. We did not see an osteolysis. So instead of doing a huge revision surgery, taking the whole instrumentation out, I just did a foraminoplasty with the manual reamers, and then I placed the cage, opened up the foramen, and the patient was doing fine, and the pain was gone. So it's just another tool in your tool set that allows you to think differently, think a little bit out of the box. And so we've been publishing papers for a long time about this kind of surgery. This one we did with Jim Yu, who's sitting here. and talking about our experience with that. Of course, there's limitations for endoscopic TLIF. So mostly, it's limited to endoscopic surgeons, obviously. And this is a problem because you need to know how to use an endoscope, you need to have the equipment, you need to have gone through the learning curve, and then of course at the beginning it takes time, all right? Of course the problem is you place small cages, yeah, that can subside. This is like one of the cages I found right now that they're selling for endoscopic surgery. Mostly they're expandable, but because of the mechanism that they have, they're expensive. So it's not always a perfect solution, right? One of the other issues that you will get acquainted with if you do endoscopic fusion is radiculitis or dysesthesia postoperatively. So because of the exiting nerve root, if you're not very careful, you don't have to harm it, you don't have to push on it. Just by working close to the nerve root, you might get dysesthesia, which is usually, it sets on 3 days after surgery. So usually your patient is already at home, he's happy, has no pain, and suddenly the pain starts, and then they get very nervous. It's neuropathic pain with sensitive alteration, temperature alterations. Very seldomly there is motor weakness. You will get no warning if you use neuromonitoring. So if you use neuromonitoring, there's absolutely no warning at all. I have tried everything. Actually, this would be interesting for a study because there is no warning with the monitoring that we use with. And the only thing that I've seen, if you have a neuropraxia, so really then you will have a temporary signal outage, you know, the potentials will go out for a minute or so and then they go back. Then the patient will have probably a motor weakness for a short time and then he will recover. But otherwise, only for dysesthesia, you will not have it. The good thing is it's transitory, it's temporary, all of them go away. Usually it's 6 weeks and it responds well to pregabalin treatment and cortisone treatment. But you have to be very careful depending on the technique, depending on the cage. It's been reported to up to 30%, so every third patient may have this. And this is bad for you, of course, because this generates a lot of noise in your postoperative follow-up. The patients will be really on you, they will be in pain, they will be miserable, and after 6 weeks they will forget about that. 3 months later they don't even remember that they were having this issue. But this 6 weeks, it's an issue. And it's an issue because it's an issue for you too. The patients call you, the patients want to know what's going on, they get nervous, and well, it goes away, it's treatable, but you don't want to have that. So the goals is that we're trying to achieve right now with this TLIF is to try to avoid endoscopic visualization if it's possible, just to open it up for other surgeons, place any kind of device, large footprint devices, and decrease the postoperative dysesthesia rate. So right now, instead of using small cages, what I'm trying to use is big cages. And I put this example here of this patient where I also I do a lot of anterior psoas, and you can see the considerable size of this TLIF cage compared to the lateral cages. So this is a huge cage that I'm using right now, 15-degree lordosis and almost 14 millimeters length. So it's a huge cage that I'm placing through the foramen. So this is not, size is not to be an issue. This is a comparison with a cage, this big cage compared to a cage that was developed for endoscopic surgery. And you can see how big the difference is. And of course, if you use this, you have advantages. You have better lordosis, larger contact surface, you have more stability, you have a lot of volume for bone graft placement, and a huge expansion. But at the same time, we're trying to fit the camel here through the needles, through the eye of the needle, right? So this is a complicated surgery if you don't do it right. You have to do a wide foraminoplasty, very careful with dysesthesia. You have no margin of error because you're with such a big cage. It's easy that if you're off but just a few degrees, then you won't be placing it right, and it's very challenging. So this is how I do it. So we have developed a special dilator to do that. So you can see the K-wire here that was already placed in the disc. Okay, so the K-wire is leading my dilator. So I'm putting the dilator into the disc. I do this everything I do it just with X-ray control. It's like placing a percutaneous screw. All right. Now the dilator is in place. It's inside the disc, and you can see it has two parts. And then I take out the dilator part, and what I end up having here is a sleeve. It's like half a sleeve. It's not a full sleeve like with the endoscope, it's only half of it. And you can see it here in the X-ray. So I know that through the foramen, I'm placed inside the disc. Then I use manual reamers, as you can see here, progressively. So I start with 8 millimeters usually, and then I go up 1 millimeter each, 8, 9, 10, 11, 12, up to 12 or 30 millimeters. And the sleeve is protecting the excitic nerve root. So I know I won't be harming the nerve root with this, with the reaming. And the reamers will take off bit by bit parts of the SAP. So I'm doing a foraminoplasty here by taking, so you can see here it's a huge reamer, yeah, it's a 12 millimeter reamer, and that I'm sliding through this sleeve. And this allows me to take out the SAP slowly and make a big foramen. And so you can see I always check, yeah, lateral view and AP. Alternatively, if you're not comfortable using manual reamers, you could use the endoscope if you know how to use it, and then you can use a high-speed burr like Vincent was just showing in the foramen, and then you can use a high-speed burr to take out the SAP and even expose the nerve root if you want to, and then you will get, of course, you will get a huge foraminoplasty, even bigger than with the manual reamers. You can see here I took out, well, almost the whole SAP just to make space for my cage. All right, so it's a big foraminoplasty that you can do with a high-speed burr. So both things are possible. By not using a full encircled sleeve, I am able to use regular instruments for the disc preparation. These are instruments for open surgery. So this is a curette, this is a rongeur. You don't have to use the small endoscopic instruments because I'm not using an endoscope anymore. I'm just using the sleeve to get through. This is the preparation that I got, just an example, the preparation that I got for this percutaneous TLIF using the transcamming approach. In comparison, this is what I usually get with a lateral approach, with an ATP, anterior to psoas open approach. So you can do an actual disc preparation, because I heard a lot of criticism about the possibilities of disc preparation. It is possible to prepare the disc well. And then you can see how I slide the cage, the big cage, using just the sleeve, into the disc by using the X-ray control, and then I place it inside. This is how it looks. This is all I see from the anatomy. So I just work with the fluoroscope, and then I can do the expansion. All right, and this is what I get. So just to give you a few ideas, like this almost 80 years old gentleman who had back pain, leg pain. You can see here multi-level severe canal stenosis. Several discs were done, so you have seen, well, Vincent has talked about this, so I don't have to talk about it anymore, about the crossover over the top. So I placed three big, huge cages here using one single incision, 2 centimeters incision. I was able to reach all 3 levels through the foramen just by using one incision. Then I used the endoscope to do the decompression. This is just the unilateral decompression. Then I go over the top, as you saw with Vincent, and then you get the decompression on both sides. And this is the preoperative CAT scan. This is the postoperative, so you see huge decompression. And then I did the posterior fixation. And well, I have a year follow-up. The gentleman is doing good. This was just the next morning after surgery. He wasn't able to walk before without the help. So, so the good thing is you get quick recovery, quick mobilization of the patient. This is just another idea, just to give you ideas. Again, I'm not saying this is better or worse. It's just another way of doing things. This 70-year-old gentleman who had 3 surgeries before, then he came with radiating leg pain, a lot of leg pain. And this was an X-ray control that he brought to me that he had from before. You can see the undersized cage here. And the X-ray control, when he came to me, well, you can see that the cage migrated and it's in the foramen. And so the question was, okay, what do I do now? So he's been operated 3 times. I have a lot of scar tissue. What should I do? And so my idea was, I did a CAT scan. I saw that the screws were solid. And so I used the sleeve that you just saw just to get there to the cage. This is the endoscopic view of the cage. I kind of improvised here. So this is like a regular TLIF cage. You can see how it moves. So what I'm trying to do here with the endoscope through the foramen is just to clean it up a bit, to expose the insertion. The handle of this cage just happened to fit through my endoscope. This was not intended. The company brought me the handle the day of surgery. I tried it out, said, okay, it fits. So maybe I can try it with the endoscope. So you can see here now, I can by turning the endoscope, I can expose it. And now I'm trying to use the handle through the endoscope's working channel under direct visualization to grasp the cage. Right? Which is usually the most difficult part, especially with the titanium cages where you can break your rongeurs if you're trying to grasp them with rongeurs. So it's a little bit of fumbling, it's tricky, but you can see here now that I was able to find the spot, and now I have the cage, and here you can see. So here you go. That was my first titanium herniation. Yeah, and I used the same corridor, the same incision to place in a larger interbody cage. Did a good disc preparation, and I used this was my revision surgery. So I did the revision surgery using a 1.5 centimeter length skin incision. I'm not saying it will always work, but I tried this and it worked out well. Of course, it's very important that you do a good foraminoplasty, otherwise you might have issues with the exiting nerve root. This patient did not have it, all right? So, and I have 6 months follow-up, but the gentleman is doing well. So we're doing this prospective study with, I have 40 cases now with this large footprint in the body cages, most single or double levels. We have significant differences between preoperative and postoperative scores, still getting up the follow-up. We should be by 10 months right now. But the most important thing for me, so the thing that I've learned, is if you use large footprint interbody cages, I only use the manual reamers, that's usually not enough to protect the exiting nerve root from temporary harm. And so I got like 28% of dysesthesia, which is too much. I use now for large interbody cages, I use endoscopic foraminoplasty, and then I get less dysesthesia. But of course, it takes you more time. If I only use the reamers, it's very quick. You just go in with the manual reamer, and I can place a cage in 20 minutes. If I have to do the endoscopic foraminoplasty, of course, it takes twice the time. All right, but of course the patients have less complications. So this is right now, it's still ongoing, but this is a bit of where we are. And this is the second part of my presentation. This will be more quick. So what I still, despite I was just doing this very, very minimally invasive TLIF, my patients were still in pain the day after surgery, and it still took them one day to get mobilized, and they were mobilized in pain. So I was at NAS several times looking for all kind of anesthesia protocols. So there's a lot of talk about ERAS protocols, but it's a lot of effort, multimodal pain management. You have to condition the patient before and after surgery. For my practice, that was too complicated. And so after looking for a long time, what I found was it's called the thoracolumbar interfacial plane block. And so you use an ultrasound to actually guide a needle between the multifidus and longissimus muscle. And you look for the plane, this interfacial plane. And this aphasia, if you can really get your needle right on there, if you inject there the local anesthesia, it's like a highway for your anesthesia. You get a huge area of anesthesia in that sense. So this is how it looks like. We use the ultrasound to place the needle there. And well, it's reported you get up to 200 square centimeters of anesthesia. So you can see the needle here going down. This is the spinous process. These are the facets. And you can see here, this is the plane between the multifidus and the longissimus muscle. And you will see now, while we are injecting, the plane goes up, it goes open. So you will see now how the plane opens up with the injection, and it just, the local anesthesia just slides through the whole plane. Yeah? So you can see it here now, how it's opening up while the needle is retreating. So it's very, very, very easy to do. It doesn't take much time. And this allows you to do this kind of surgery. Well, I don't think this will make a big difference if you do a big open surgery, but if you do MIS surgery, then you can get a very nice effect And you can do, well, I'm doing awake fusion, so I'm doing one-level TLIFs with the patient awake. Okay, so we did this study, single-level TLIF cases, multiple surgeons, one center, prospective study with a retrospective case control, and we did a group with the TLIF block, a group without the TLIF group, and monitoring for all of them. And the most important part, we did the same postoperative analgesia protocol for all of them, all right? And what we did is we gave them a PCA pump that the patient could trigger manually, and we could just register the triggering. So we would know when the patient was really in pain, when he was needing more. And so you can see the demographics here. And so if we take the look at the group that got the block, you can see that we have significant differences between the preoperative and the postoperative scores at discharge. This is always a discharge. When we have the group that did not receive the block, we only had significant differences for the leg scores. And when we compare both groups, so preoperatively there was no significant difference, and postoperatively, then we saw that there's a significant difference between the group that had the block than the one that did not. And you can see it here graphically. So it's always a discharge. Of course, after 1 month, the results, they get non-significant different. So it's just the immediate postoperative period where we get a significant difference. If we get a significant difference for the TLIF block, despite that not one single patient triggered the PCA pump. So we had not one patient requiring opioids after a TLIF surgery, while the non-TLIF group required a medium dose of methadone of about 23 milligrams. Okay, so they triggered the pump, and despite getting opioids, the results were worse. So we've published this recently and in some journals. And just so you get an idea, because theory is nice, but in the end, a video is what always opens the eyes. Because in the beginning, I was surprised myself. So this 56-year-old female had a lot of back pain. So you can see here, grade 1 spondy. All right, she was, well, a big patient. I did a one-level TLIF. You can see here the skin incision for the placement of the cage. And this is the patient. So I did this in the morning. This is just a few hours after surgery. So this is the patient in the immediate evening. This is her walking. And if you look at her face right now, look at her. She's smiling. And she did not take even an ibuprofen. She did not want any kind of non-steroid, and nothing. She didn't take anything. And we have a 1-year follow-up now. She's still doing great. But I was surprised about the effects. So she did not take any kind of analgesia. Of course, after that, you have to warn your patients, because when the block wears off, they will start to feel something, but they are already mobilized, they're already confident that they are okay, and it is much less stringent on them. Same with this 50-year-old male. He had lumbar discectomy before on the 2 levels. I did a 2-level surgery using 1 skin incision. And again, this is just a few hours after surgery. Him walking through. So this is really very interesting. We have also 1-year follow-up. The patient is doing really well. He's a truck driver, has a lot, strong work. And I also combine this technique when I also do lateral approaches or anterior approaches. So this 76-year-old female, she actually was bound to a wheelchair because of the pain. You can see here multi-level spondies, foraminal stenosis at different levels. So for the upper levels, I did the anterior to psoas approach. For L5S1, I placed the transforaminal cage. So I did a combination of different techniques, right? So this is the ATP incision. This is the posterior incision. And again, you can see the wheelchair here. She was bound to the wheelchair for the last 2 years. And this is the next morning after surgery. And here she is walking. So again, even especially for the older patients, where you really want to mobilize them as quickly as you can for reducing the rate of complications, I believe that this technique can be very interesting. So in conclusion, my strategy is I try to combine endoscopic percutaneous TLIF. Be careful with what kind of cage you use. Be careful with the system that you use. Be careful with the postoperative dysesthesia. do a big foraminoplasty, and I combine it with a block, and these two things combined have given me very nice results. No need for opioids, at least in the first days. You can do it awake. The patient is moving very quickly, and most of my patients go home after 1, 2, 3 level surgeries in the next morning. And that's a little bit it. Thank you very much.